The content shared here is for informational and educational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Welcome back. I'm Ruth Ann, and this is For Those Who Care, a podcast dedicated to caregiving. I'm pleased to have Dr. Carolyn Larkin Taylor back for another interview. In our previous episode, we talked about her book, Whispers of the Mind, a Neurologist Memoir. And today we're going to talk about Lewy Body Dementia. Dr. Taylor, thank you for joining me again. Lewy Body Dementia is one of the toughest diagnoses out there, and I'm so glad you're here to talk about it.
It's my pleasure. It's my pleasure. It's very important disease to familiarize the general public with, because I don't think a lot is really known about it.
Well, for the listeners who've never heard of it, can you start with the basics? What is it and why is it so often misdiagnosed?
Well, Lewy body dementia is a progressive neurologic disease that does lead to dementia, and it is characterized by the collection of these abnormal proteins in the brain called Lewy bodies. And that's what distinguishes it pathologically from something like Alzheimer's disease, which is a collection of different abnormal proteins, amyloid plaque and tau protein. So that part is only important in the sense that it presents differently and has different characteristics. Lewy body dementia is more associated with decreased levels of alertness, inattention, visual hallucinations. It is also associated with many Parkinsonian features, so it's often confused with Parkinson's disease. These people can have stiffness and slowness and loss of balance, and for all practical purposes, if you watch them move, you might think, oh, this is a Parkinson patient. So it's important to distinguish it from Alzheimer's disease and other forms of dementia, because what a caregiver and family can expect from the progression of this disease is very different. And the treatment for the two different diseases are different. And some of the medications that might be used in an Alzheimer's patient, for instance, might make a patient with Lewy body dementia worse. So it is very important to distinguish the two diseases and help a caregiver know what to expect, because they might think that their loved one is doing something on purpose, or they might think that they're developing psychiatric disease, when it's just all part of the Lewy body dementia disease, and understanding it allows them to be a little bit more understanding with what's going on. And the more understanding you are and with what's happening, and the less you fight it, the easier I think it is for the patient. But it's so hard to do.
Having taken care of my husband who had dementia, wasn't Lewy body dementia, but any form of dementia, I've always said you have to realize that you're living in their world, and their world is different than the world as we know it. So I tried to just meet him where he was at. I didn't always do it. I lost my patience too, but it made life so much better when I was able to just meet him where he was at.
Yes, and you can do that for a few hours, but when you're doing it 24 hours a day, it's normal to lose your patience and just want to say, no, I just told you that, when he doesn't remember you just told him that. So, but you get very frustrated, and that's where, caregivers need a lot of understanding and help.
Right. And self-care.
Absolutely, absolutely.
Well, how is Lewy body dementia diagnosed?
Well, there is no test for Lewy body dementia, unfortunately, but it's diagnosed by ruling out other things. You need to rule out other things, that medical conditions that can cause someone to have a dementia-like picture, such as nutritional deficiencies, infection, metabolic disturbances. And so you often will start with the primary care doctor, and they'll go through all of those things. And when it comes down to, well, everything's fine medically with this patient, then you want to go and see a neurologist. Any general neurologist should be able to diagnose this condition. It's different, whereas Alzheimer's disease, well, let me back up a little bit. We're talking about diagnosing it. You rule out other conditions, and part of that's going to be getting head imaging studies, maybe a psychiatric evaluation, maybe formal neuropsychological testing to find out, which is a very extensive testing of the memory, about a 3-hour test performed by a neuropsychologist to find out exactly what parts of their memory seem to be faltering. Is it short-term memory? Is it reasoning and problem solving? Is it attention? Is the patient depressed? There's all those things that need to be sorted out. So when you rule out other things, and they have these characteristic findings of inattention, problems with arousal, where there can be lucid moments and then moments when they just seem to be totally confused. Visual hallucinations are a hallmark of this condition, which you typically do not see early on in other types of dementias. They can occur later on in those diseases, but early on, it's not typically seen, but it's classic for Lewy body dementia. Also, these patients tend to have a sleep disorder. So it sneaks up on you. You're in bed with someone, and all of a sudden they punch you in the middle of the night, or they kick you, or they swing, or they fall out of bed because they're fighting somebody. And that's not normal. When we're dreaming, this all occurs during REM sleep, which is when we dream, that they do these things. When we're dreaming, we're typically paralyzed in our dreams and we don't act out in them and we don't move. But in a patient with Lewy body collections in their brain, that is gone and they start acting out in their dreams and fighting. So that's called REM behavior sleep disorder. And that is also very characteristic of someone with Lewy body dementia and is a tip-off that maybe they have this. Now, you might say, well, dementia is dementia, and that's true. And why does it make a difference? And it does, because how you plan for the future for each patient is going to be very different. The patient with Lewy body dementia that develops hallucinations, if you try to treat them like you would treat hallucinations in someone with psychiatric disease or Alzheimer's disease, the drugs you would use will make the Lewy body patient worse, far worse. So you have to avoid treatments that will make them worse. And you also need to educate the caregiver very carefully that if they're acting paranoid or psychotic in some way that frightens you, that's part of the disease. And it is very helpful if you just understand that. And the lucid moments are very confusing to people because all of a sudden they seem normal. And you think, oh, what is this? And then in a second, I like to call it the dimmer switch. It's like someone dims a switch and all of a sudden they're confused again and they're inattentive and they're seeing things and seeing little people and talking about psychedelic experiences as if someone had just given them LSD, and it's very frightening to the caregiver. It's also very frightening when they have this REM behavior sleep disorder, and you need to protect yourself, perhaps by not sleeping with this person in bed because you could get punched. And you also need to protect the patient and not have a nightstand right next to them where if they fell out of bed, they could hit their head on the nightstand or hit their head on the floor. You might want to have pillows all around them on the floor in case they start fighting with someone. And again, there's medications that sometimes can be helpful. So the treatment for the two diseases, although neither disease is curable, the treatment is very different.
Are the medications effective for Lewy body dementia, or does it just depend on the patient?
It depends on the patient. We'll often use treatments that might help them a little bit. A medication, for instance, that's often used in an Alzheimer's patient called donepezil or Aricept is a medication that allows the patient to hold on to more of a particular neurotransmitter called acetylcholine that helps transmit information from one neuron to another. So it facilitates information processing speed. A patient with Lewy body dementia may get some benefit from that. They may get some benefit at night from taking something like melatonin, but you can't give them anything that is going to affect their dopamine levels in the category of a medication that's an antipsychotic, because that can just make them far worse and make them even more, act more psychotic. So nothing helps tremendously, I have to be honest, except avoiding things that are going to make it worse. It's a lot of vigilance, making sure the patient is safe. It's a lot of reassurance to the patient that someone isn't really after them, that this frightening thing they're seeing isn't real. It takes a lot of assurance, and they're so convinced it is real that it can be frightening for them. And that's the hard part. And when we talk about that, I think people will remember Robin Williams, and he had Lewy body dementia. And I think in his lucid moments, he knew what disease he had, and it frightened him terribly. And in his other moments, as you can imagine, if you become psychotic, reality doesn't exist anymore, and things are happening that aren't really happening, and they can be very frightening. That his existence was a very, very frightening one. And you can understand why a man like that would take their own life. And of course, we don't want that, because there are lucid moments, and that's such a judgment call. But educating the caregiver as to what to expect is so critically important, as you can understand. And also, with Alzheimer's disease, we want to talk about the difference. With Alzheimer's disease, it's more of a short-term memory issue, especially early on. They forget what they were just told. It's less of a behavioral issue, although that can occur later, but it's not the psychosis and the frightening paranoid behavior and hallucinations that the Lewy body patient will develop. And it all has to do with these protein deposits in the brain, whereas with Lewy body protein aggregates that accumulate, it disrupts neural circuits, and it disrupts and segregates them in a way that Alzheimer's proteins don't. And that's why you get these lucid moments fluctuating with levels of decreased arousal and pure psychosis. Also, the Lewy body patient looks Parkinsonian. So at first, they're confused. So people might think it's an Alzheimer's picture, but yet they look like they have Parkinson's. So they might think this is Parkinson's disease. They have all those features, but it's actually separate and distinct. And interestingly, when we do autopsies on these patients, a lot of people with Lewy body dementia also have Alzheimer's disease. So you can see the two pictures simultaneously. And why that happens, we don't quite know, except there must be something that predisposes us to one condition that can predispose you to the other, even though they're separate diseases.
So it could be that a patient who is diagnosed with Alzheimer's down the road could develop Lewy body dementia.
Yes. Yes.
Okay. What are the first signs of Lewy body dementia?
The first signs of it are looking Parkinsonian. And actually, it's often diagnosed as Parkinson's disease early on, when they're brought to you as a neurologist, when they're brought into me. And then they don't respond as well to the Parkinsonian medications, interestingly, as a pure Parkinson disease patient would. And then there's levels of inattention, and they're not quite themselves. And the spouse may tell you, that he's acting a little strange, or they might still be going to work, but even the people that work with them say, they're not acting like themselves, and they seem to be inattentive. They seem to be sleepy at times, and then other times they seem to be, quite normal. So it's the Parkinsonian, and then the visual hallucinations start quite early. And that's unusual in someone with early dementia. It's unusual with someone with early Parkinson's disease. That and the REM behavior sleep disorder occurring like all around the same time is a tip-off. If someone comes to me and they look Parkinsonian, and I don't really elicit that history of the inattentiveness that is beginning, and a wife tells me that their husband is starting to hit them in bed and they're acting out in their dreams, it's a red flag right there, that we might be looking at a Lewy body dementia patient. And only by following them over time, because there's no test for it, do all the characteristics just present themselves, and it's that clear diagnosis. But you have to be very attentive. You have to be looking for it. But I'd say the REM behavior sleep disorder and the visual hallucinations are the primary things that are going to be a red flag early on.
So if a patient has been diagnosed with Parkinson's or Alzheimer's and they've been put on treatment for those diseases and it's making their symptoms worse, it could be Lewy body dementia.
It could be. The treatments that are more likely to make them worse are treatments for their hallucinations. And it's almost diagnostic that, you're not dealing with, for instance, if someone presents with hallucinations and they're a little bit Parkinsonian, it might be misinterpreted as psychiatric disease. Sometimes these people get put in that path, sent to the psychiatrist. And then when they try treating them, they get worse. And then at the same time, they're noticing they're getting a little bit more Parkinsonian. Now, it's interesting, and it can be very confusing at first, which is why you need to follow these people and always reserve the right to change your mind about their diagnosis, because the psychiatrist that might treat a patient that's presenting with new onset psychosis may treat a patient with an antipsychotic, which blocks dopamine for the psychosis. But by blocking dopamine, they also can make this patient artificially Parkinsonian. So sometimes they interpret the development of Parkinson symptoms as, oh, this is a side effect of the antipsychotics. I put them on for their psychosis. But it's not. It could be, no, this is Lewy body dementia that's actually coming out. But we get the patients pretty soon when the psychiatrists realize the antipsychotic medications make them even more psychotic, which should not be happening. And that's kind of, psychiatrists and neurologists are married together, and we're all under the same board. It's American Board of Psychiatry and Neurology. We're double boarded. They take courses in neurology. We take courses in psychiatry because there's so much overlap. But that's the tip off. They'll go to the psychiatrist. They get worse with the antipsychotic medications, and then we get them. And then the whole picture starts to fall into place like pieces of a puzzle. This is looking like Lewy body dementia. And it's a more unfortunate disease than pure Parkinson's disease and even Alzheimer's disease.
But someone with Parkinson's could also develop Lewy body dementia.
Yes. And that is a different animal. It's classified as different from Parkinson's with Lewy body dementia. And I'll explain the two in a minute. Lewy body disease presents with the hallucinations and the lack of the fluctuating memory that you get from the accumulation of these Lewy bodies, and the mild Parkinsonian symptoms that develop kind of simultaneously. And we've discussed that pretty much in detail so far. People that develop Parkinson's disease typically have a longer, more drawn out course, and you're treating the movement symptoms of Parkinson's, the slowness, the tremor, the shuffling gait. And down the road, 5-10 years, they start accumulating some Lewy bodies as part of their Parkinsonian syndrome in their brain. And they can develop, after they've had Parkinson's disease for many years, a dementia with Lewy bodies. And they'll get all the symptoms we mentioned with pure Lewy body dementia. But they occur down the road. It's a much older patient that's had Parkinson's disease for years. And not all Parkinson's patients develop that. Whereas a Lewy body dementia patient, it's primarily the dementia, and it develops at a younger age, and it fulminates all much earlier. Treated the same though, but it's classified differently. For all practical purposes though, I think in terms of what's difficult to diagnose and what can be confused with psychiatric disease and Alzheimer's, it's the Lewy body dementia patient, not the Parkinson disease patient that later on develops Lewy body dementia. It's so confusing because we call them both Lewy body diseases, and they are, but their presentation is entirely different. And so much easier to diagnose the patient who's had Parkinson's disease for a long time that then develops a Lewy body type of dementia. You're kind of expecting it. Whereas this patient that all of a sudden presents and they're maybe only 60 years old they'll present younger, like Robin Williams did, with psychosis, hallucinations, and gee, they seem demented sometimes. That, oh, and by the way, they're kind of stiff and they hold their arm in a funny posture when they walk. But that's not the overwhelming picture. The overwhelming picture is the psychosis. And I would say they're more likely to get into a psychiatrist before they get to me. So you follow them clinically and you treat them clinically based on their presentation and what works and what doesn't work. But having some way to separate them out, it's like a pie, and there's different slices of the pie. Well, this is Alzheimer's, this is Lewy body, this is frontotemporal dementia, this is vascular dementia. There's a lot of overlap, and it's following the patient over time and treating what comes up next. And lo and behold, you can say, oh, this is this, we know what this is now, and this is what you can expect. And this is how it's more for the caregivers. This is how you need to treat the patient. This is what assurances they need. This is how you can keep them safe. And that's what trying to figure out what someone has is all about, is helping the family plan.
Right.
Until such time as we have effective treatments and cures, then of course, it's important to rush in and get an exact diagnosis right away. And that might even prompt the brain biopsy if we had a cure. But right now, a lot of it's geared towards helping the family.
So are there ongoing studies for this and testing of different medications?
There's always ongoing studies for this. It's a very hot topic of discussion, and how can we diagnose this earlier and earlier? For instance, we know that there's certain genetic markers for people that are prone to Alzheimer's disease. They contain certain alleles, and you can have multiple alleles that would strongly put you in that direction, but it doesn't mean you're going to develop Alzheimer's disease. So there's a lot of environmental factors that can turn those genes on and off. And so we can counsel people on things they can do in their life if there's multiple family members with Alzheimer's and they're so afraid they're going to get it because of that. Not necessarily. And it's not necessarily advantageous to check their genetic predisposition for it, because it doesn't mean they will. And it'll only scare them, because we can't prevent it other than altering your environment to encourage you to live a healthier lifestyle. Don't smoke, eat a healthy diet, get exercise, anything that decreases inflammation. We know that those people, maybe those genes won't turn on. And it's very interesting, for instance, they recently discovered in patients that develop traumatic brain injury, the football players, the chronic encephalopathy that we talk about. And it was thought that it had to do with how many hits you took to your brain. But they recently discovered that you can have a few hits to your brain and develop this condition, or multiple hits to your brain and develop this condition. And why? And they have discovered that the people that have had trauma to their brain, classically the football player, the boxer, if they had these alleles for Alzheimer's disease, they're more likely to develop this encephalopathy down the road. So we're learning a lot about the combination of your genetics and your lifestyle. And you make the argument, the athlete that wants to go into boxing or wants to be the professional football player, maybe we should test them for Alzheimer's alleles. Is this running your family? Because we can say to them, you might go on to develop chronic traumatic encephalopathy from playing football, or you are less likely to. And that's an interesting thing. They're doing a lot of work with dopamine receptors in the gut. The gut is a hot topic of debate and research right now, because that seems to be regulating a lot of things. And we've discovered that Parkinson's disease, for instance, starts in the gut. There's a lot of dopamine receptors in the gut. And perhaps if we identify those receptors, we could diagnose Parkinson's disease in the gut before it works its way up to the brain. If we could alter that, we would alter it at that stage before it's up to the brain. So it starts in the gut. Patients with Parkinson's disease have a lot of gut problems. They have slowing down of um, the gut, so they become very constipated, and that's one of the early symptoms of Parkinson's. Before you look like you have Parkinson's, is change in your bowel habits. And then another early symptom of Parkinson's is loss of sense of smell, because as it works its way up from the gut, it gets to the olfactory bulb, and then it gets to the brainstem and the other parts of the brain, and then the patient looks Parkinsonian. So Parkinson's disease starts many, many years before a patient looks like they have Parkinson's. So if we can develop it, identify it at that stage, and we know of anything environmentally that can alter it, or that we have a drug, for instance, we don't yet, but they're always looking, then that's the stage you want to treat it. Diet. They were learning a lot about diet, and diet plays a role, we know, in Alzheimer's and Parkinson's. For instance, anti-inflammatory diets. So any inflammation in the brain can hasten the development of what we might be genetically predisposed to. Trauma causes inflammation, for instance. So anything that causes inflammation, and leading a healthy lifestyle. And I think diet and exercise are key. Getting enough sleep, we're also finding out that that's key. Our brains heal at night and kind of clean up and scavenge a lot of that inflammation when we're sleeping. So getting proper sleep is very important. And you hear all these things, and people may tend to kind of poo-poo them. Oh, how much does that really matter? It does. It does matter.
Mm.
And so I think there's a lot we can do. In the end, we're all going to end up in the same place, but we can we can go far to postpone that and live our best life until we do end up in that place. Even like cancer, there's oncogenes, but something has to turn them on, and some things can turn them off. And we've noticed that, for instance, with the whole vitamin D theory. We noticed that people with multiple sclerosis were more likely, people were more likely to develop multiple sclerosis if they lived in the northern latitudes. And then they noticed that there was some connection with vitamin D. Years ago, when people had tuberculosis, they found out that if they sent them south to sit on these um, sanitariums where they sat them out in the sun, they did better. And it probably had to do with the effect of getting vitamin D, which has a good effect on your immune system. And so vitamin D helps regulate the immune system in some way, probably helping to turn some of those genes off and on. And so there's many things we haven't discovered yet, but leading a healthy lifestyle with regard to vitamins, sun exposure, anything that reduces inflammation, um, can help alter those genes. So I think that's an important area of research and things we can do right now.
I saw it myself firsthand, the difference
Yes,
that it made just living a healthy lifestyle.
yes, it makes such a difference, such a difference.
Yeah.
And we've all become less healthy because of the ultra processed foods and everything. I think we're starting to wake up to that. But certainly we need medicine as well, especially once the disease is there. Sometimes that's the only way to effectively treat it. But I think we can go a long way to preventing disease if we can all try to live a healthier lifestyle. And it's hard in this busy, fast-paced world when we're not getting enough sleep and we're drinking too much caffeine and we're stressed. And again, a lot of it comes down to taking care of yourself. I like to tell this story of a patient that I followed for many, many years. I diagnosed him with MS when he was a young man and had a young family, and was the sole support for his family. He was one that had his career, and his wife stayed home to take care of the family. And he was so worried, what's going to happen to them? What's going to happen if I'm going to be disabled? What are we going to do? I have to start planning for those things. And I said, well, it's okay to start planning for those, but no reason to think that's going to happen to you. And, you know, encouraged him in all these things, also treated him with one of our best medications to help regulate his immune system for MS. And it's very, very important to treat these patients once they have the disease. I don't want to say don't go that road. You should, but you can do both. And I'll never forget, he came back to me 20 years later. I've been following him all these years. And he was doing well. He'd gone on, had two more children, and he said, I never forgot the advice you gave me, and I live more in the present. And he said, I lived a better life than my colleagues who were trying to climb that corporate ladder. We both got there, but I didn't take it as seriously. I took vacations. I spent time with my family. I took care of myself because I didn't know if I'd be able to run around and play ball with my kids 5 years later. So I did everything. I did everything. We went to Disney World. We did everything. I didn't just send them without me. And he said, I lived a better life and I'm happy and doing well. And he attributed it to the fact that he did have a disease and knew that his time might be limited. He lived a fuller life. And he said it was a gift that I got MS because, yeah, I'm doing okay. I'm doing well despite it, but I lived a happier life. And so it goes back to living in the present. We talked about that in our last podcast, that living in the present will make you a happier person because we're all going to deal with something, get something, and we're all going to, as we mentioned, end up in the same place. But it's how you live your life
Mhm.
that is, and what you make of what you have that is what's so critical. And I've learned that in all my years of practice. I didn't know it when I was starting out, but it's a wisdom that I, as a seasoned practitioner, can now impart to patients much better than I could when I was starting out. I learned with them and they taught me.
I think one of the really important things, and we've talked about it a little bit, is self-care. We all need to do that as a patient and as a caregiver. We all need to take care of ourselves so that we can
Yeah.
continue to care for our loved ones around us.
Yes. Yes. It's so very, very important. And we have to take care of ourselves or we can't take care of them. It's, the oxygen mask on the airplane. And it's so critical with a lot of these neurodegenerative diseases, any dementias in that category, that we um, take care of ourselves because the caretaker is living with that disease 24 hours a day. As a doctor, I can spend an hour with someone and then I can go home to a normal family, but that person lives with it day in and day out. And it's very, very critical that they take care of themselves. And especially as we're talking about Lewy body dementia today, the Lewy body caretaker has to particularly understand that a lot of what they see is part of the disease so that they can be more patient with their um, loved one. And one of the positive things about the Lewy body dementia diagnosis is they're going to have more lucid moments with them. And you want to hold on to every moment you have when they know you and can talk to you like they used to. And that's a gift. And then it might be gone, like that dimmer switch goes on and it's gone. But they had those fleeting moments and you want to be there to catch as many as you can. I talk about a story I wrote about a Lewy body dementia patient in my book. Um, he was pretty far gone and his keys to his car had been taken away from him. And he was at the point where they were getting ready because they had to put him in a nursing facility. Um, he had this lucid moment that went on for quite a few hours. He got his keys and he drove over to my office and he came in to talk to me. And I was just alarmed. We've got to call his wife. We've got to get him home and get him to safety. But he was as lucid as he was the day I first met him. And we had this long talk about his thoughts about why he got the disease and maybe it was some payback for something he did earlier in his life. And I was talking to a normal person. And just like that, the switch went off and I had to make sure he didn't drive home. But that's a little gift that the Lewy body dementia patient gives to their caregiver. Because if you watch, they're going to turn on and off and you get those lucid moments. But when they're psychotic, you also have to understand it's not on purpose and you have to just give them a lot of reassurance and keep them safe. Keep the keys away from them, have the pillows next to their bed when they fall out of bed having a fight with somebody. So safety is another big, big issue.
I'm just curious, would a security door work to keep a Lewy body dementia patient safe?
Yes, that is helpful. There's all kinds of things. A security door. There are on the newer stoves today. You'll notice if they deal with gas, there's a lock where you can turn it off. So if you're not there, or don't happen to just be in the room, you might be in the house, but you can't be right next to them 24 hours a day. They can't turn it on, and they can't figure out how to unlock that. And so they can't hurt themselves, but yet you're not kind of taking something away from them. And get very upset when you take their keys away from them and take away their freedoms. And they might feel like they're locked up. And so a lot of education has to go into how to deal with um, patients with dementia so they don't feel it as much and they don't feel resentful and angry because they can. And you have to take advantage of the fact that they forget things and reorient them to something else to take their mind off of something that they're angry about. Like, and it's usually somebody taking away their freedom, not allowing them to go out for a walk or not letting them take a bath alone. Because, what if they lost consciousness and drowned? And there's so many things you have to think about. But it's as you know, it's a full-time job taking care of a dementia patient. So they need help. They need respite. They need people to come in and give them time to get out and be alone or just get away from it all. And I encourage people, if they can, to put their loved one maybe in a nursing facility for a weekend where they'll get care. And so they can get away for a weekend if they don't have family that can come in or good friends that can watch their loved one for them, because you have to get away.
Yep.
And that's part of the care of the patient, because you're better with them if you're rested and you've had some respite and now you have more patience,
Yes.
because we don't have extended levels of patience. None of us do. That's normal. And you have to have sleep.
Yes, and actually that's really great advice. I did use nursing home care for many years. I would put my husband in there 2 to 3 times a year, 5 to 10 days, because I needed that break. He was 24/7 care for the last 12 years of his life, and I couldn't do it full time without a break. And I mean, a lot of times I would put him in there and I would go home and sleep, clean
Yeah.
my house, do the things
Yes.
that I couldn't do when he was in the house and needed me constantly. And,
Yes.
and there's
And
nothing wrong with that.
there isn't. And there's some people can't afford to take off from work to take care of a loved one. And I always encourage patients, caregivers, not to feel guilty, because there's going to come a time when you're going to need to put them in a care facility because you can no longer do it. And at that point in time, they might not realize that you've left them or feel like you've left them. And I try to put it in the terms of you're better off spending what time you do have talking to them, reading to them, reminiscing about memories, playing a song you knew that they liked. It's more quality time than changing their diapers and bathing them and doing things that may be making you resent them. Leave that care to someone else that's skilled at it, and you spend quality time with them. And then you can get away and you can rest and take care of yourself so that when you do go back, you're giving them quality time again. And you have to take that guilt away from them, because the caregiver is just riddled with guilt when they get to the point they can't do it anymore. And at that point, it's not appropriate really to do it anymore.
Right.
You're not harming your loved one. You're actually caring more for them by doing that.
Yep. I would agree with that. That's great
Yeah.
advice.
Years ago when I was growing up, many years ago, it was the extended family. Your grandparents lived with you, and everybody lived in the home. They all helped take care of that person. But we're all so scattered now, and families don't always live in the same home anymore and even in the same city, that it's just much, much more complicated.
Yep. It is. I've talked to a lot of people who have they've worried about their parents living so far away because they're starting to show the signs of dementia, and how do you get them closer to you before it gets
Yes.
so bad that it's hard to move them?
Yes. And they don't want to give up their freedom. So it's a hard thing. And I'm trying to prepare now. I only have one child and he's gonna be the only child dealing with this. And it's always nice when you can spread it among siblings, but I want to get everything in place so I don't burden him. And it's a hard thing to do.
Yeah. And I think it's really important to have those conversations too, while you're still young enough to have those conversations.
Yes, yes. And that's all the whole purpose of a living will, and what you want and how you want it done. And sometimes I think we should tattoo it on us because it's difficult. 'Cause I was the one for 3 family members that had to make those decisions for them. And it's hard. It's hard. But as a neurologist, I knew the real difference between a meaningful neurologic recovery and one that isn't. But it's hard to do. It's hard to do. So we all should think about it ahead of time.
Because it can happen at any age. You just never know.
It can. It can. And so again, it goes back to living in the present. And so that's hard to do too, isn't it?
It's not so hard now. It took a while to get used to doing that, but yes, it can be hard living in the present. And you think about making these plans for a future where you could become disabled or sick or on a ventilator, whatever, and you don't want to think about that because you want to live your life. But those are really important conversations to have and really important plans to make so that you don't put that burden on your loved ones.
Yes, absolutely. Absolutely. And you only start to think of that if you've been through it yourself. Like you're thinking about it because you
Yep.
lived through that with your husband. But there are people that go through life that never dealt with it. And it just didn't occur to them. And it occurs to everybody as they start to become elderly, but the young person that becomes devastated with something, it's something that, we're not prepared for.
Right.
There's probably no reason why we should be, but it happens.
Just really quick back to Lewy body dementia. I'm just wondering if a family suspects it in a loved one, what's the first step they should take and how can they find a doctor who really understands the disease?
Well, a doctor who's really going to understand the disease is going to be a neurologist. And a general neurologist should be um, very good at that. There are specialized, cognitive centers, memory disorder centers where you might have someone that just specializes in um, various types of dementia. And not everybody has access to an academic center or a city where you might find that type of specialization. But a general neurologist can do this. They are tuned into, the diagnosis of the different forms of dementia and helping the caregiver and the family know what to expect and what types of medication to avoid. The very first place to take a patient when you suspect that there's something wrong is to the primary doctor, because I mentioned earlier, there's all kinds of medical conditions that can fool you and present as dementia. It can be nutritional, it can be toxic, it can be metabolic, and that's the first place to start. And then your primary care doctor would be the one to then refer you on to a neurologist. The particular problem with the Lewy body dementia is that they can present as a psychiatric patient. They may get put in with a psychiatrist first, and then they can go down this long road of trial and error of medications that don't work before it becomes clear. And for the caregiver, I would say if the patient develops the REM behavior sleep disorder, always think this could be a neurologic dementia presenting and not a psychiatric condition. And often they might take the patient to the psychiatrist. They may go down this long road of psychiatric medications and trials and errors, and the family may never even mention to them about acting out in their sleep. That might not come up. And it doesn't occur to people, but that's the biggest red flag, I think, is a REM behavior sleep disorder. That should be a red flag to a person, a caregiver, a spouse, that something else might be going on here, something else might be wrong. Saying that, not everybody with REM behavior sleep disorder has a dementia or will develop it, but most of them will. And that's a red flag that, there's something more to this odd behavior than depression or psychosis.
Well, is there anything we haven't talked about that you would like to add?
The biggest thing here, and I admire you as a caregiver, is caregivers, take care of yourselves. You have to take care of yourselves, or you aren't going to be able to take care of your loved one. With
Yes.
all the dementias, all the neurodegenerative diseases, and other things, take care of yourself first.
No matter what anyone else says, it is not selfish to take
It
care
is
of.
not. It is not selfish. You need not feel guilty, and you need not feel guilty if you can't care for your loved one at home. There are facilities where they can get excellent care, and you can still be there and be their loved one at a level that is more satisfying to both of you.
Great advice. Thank you.
You're welcome.
Well, Dr. Taylor, thank you so much for taking time out of your busy schedule to share about this challenging and unpredictable disease and for talking about all the other dementias and caregiving as well. I so appreciate your time.
It was my pleasure. I love to educate people. That's part of being a doctor. If you have the education and the knowledge, I think you can really care for yourself and your loved ones much better.
There are resources available to help manage the challenges of Lewy body dementia. Caregivers can find support and information on managing symptoms through organizations such as the Lewy Body Dementia Association and the National Institute on Aging. Thank you for listening, and be sure to hit subscribe so you're the first to know when a new episode is available. I'll see you next time.